where does the mandible articulate with the remainder of the cranium? On the temporal bone. So you need to know that, because when I put a dot on that mandibular condyle or condylar process, and it will say name the structure, oh, mandibular process or condylar process, name the bone that articulates there. Temporal bone. Temporal mandibular joint, TMJ. Some of you might be plagued with TMJ, where the joint then is not as rigid as it should be. There's flexibility, and so the jaw moves side by side, and then you have sometimes problems with chewing, okay, etc. Headaches sometimes that originate from that. Some people can't chew gum because of that. So that temporal mandibular joint is the weakest point where that mandible is going to then articulate with the cranium. So again, it's where two bones are going to come together and meet. So what it does, joints allow for mobility, obviously. You know, we're looking at my knee and we can go ahead and walk as a result. And these joints hold the bones together. Okay, so the skeleton is held together by way of these joints. Now we can classify the joints in two ways, by their structure and by their function. Okay? So structure implies what kind of material do I have at that joint. Okay? Function implies what is the activity associated at that joint. So let's look first at the functional classification of joints. And it's based upon the amount of movement between those joints. Some joints are almost immovable, like the sutures. Your parietal bones don't move. You know what I'm saying? So the sagittal suture is going to be relatively immovable, right? And that's going to be much different than a joint that I have at my elbow. So there are going to be variations in the amount of movement that are allowed. So I've got three functional classes. The first one are the synarthrotic joints. We refer to those as being immovable. And they include such structures, so there's synarthrosis, and they include then my sutures. Now the sutures do not ossify. Well, let's go back for a moment. Okay, so they're relatively immovable. There are fibers that hold it together. Dense regular connective tissue hold it together. And these bones can over age ossify. So the suture becomes obliterated. The membrane is replaced with then bony tissue. Okay? So during fetal development, those suture lines are very flexible. Those bones have got to fold over each other in order to make their way, the skull, the head, through the vaginal canal. Okay? It's got to be able to make its way out. So they're very flexible. Over the course of time, these sutures become ossified. The most important one was the one that I left out with the fetal, it was a young child skull, which has the anterior fontanelle and was still open. That's the last one that should be ossified. And that allows for the expansion of the brain. Because compare a newborn to a 2-year-old toddler. Compare the head size. So what they're going to do, your pediatrician's got to measure then the circumference to see that it is essentially the brain is developing as it should. Okay? We don't want to have premature closure of those sutures. And then eventually at about 2.5 years of age, all those fontanelles are now closed in. And then over the course of time, you'll find that different joints, different sutures are going to ossify. So you can tell the age. If you're a forensic pathologist and you found that skeleton out in the desert, how old was the person that is associated with that skeleton? All you have to do is look at the suture lines and be able to tell then the degree of ossification. So it's completely ossified on the inside about 35. Then it's going to get more ossified on the outside the older you are. So you can then age or calculate the age of that person. So the first one are the functional classes, which are the synarthrotic, immovable. typical, those are gonna be my sutures. So, which of the following structures would be found at a synarthrotic joint? That's the kind of question I'm gonna ask. Okay, so what you wanna do is you wanna go to the back of the chapter and be able to then answer those multiple choice questions that are in there, or use Quizlet, or use My AMP Lab, which then has some quizzes in there as well. The second type are amphiarthrotic joints, and these are slightly movable, okay? And so they're not gonna be like the elbow, okay, like that, but they're able to have some flexibility. So examples of my amphiarthrotic would be then my, this is still a synarthrotic, would be then, it's not this one here, slightly it is, okay, would be my intervertebral discs, okay? My diarthrotic joints are those that are completely movable. They're the most freely movable. That would be what we see here, where the head of the humerus is then going to articulate into my glenoid cavity of my scapula. Okay, and so then I'm going to have a series of structures that are associated with that to reduce the amount of friction that might be present where those two bones come together. These I don't have to worry too much about because there's a cartilage here and there's a membrane here. So we don't have that much movement. But when I get to this point here, I need to have a number of different features in that joint to allow for an enhanced flexibility. So my three functional classes are synarthrotic, my amphiarthrotic, and my diarthrotic. Okay? So those are my functional classifications. Now the structural classification refers to what kind of material is found in that joint. How complex is that joint? So the three structural classifications are fibrous joints. So these synarthrotic joints are also fibrous joints because we have now dense, regular connective tissue that holds the bones together. Okay, that's what we're going to find, and they're fibers, collagen fibers that we're going to find in that joint. The second type would be the cartilaginous joints. These are the ones where I have then my cartilage present. Example would be my intervertebral discs. That would be then a cartilaginous joint. My symphysis pubis, which you've already learned as fibrocartilage early on in the histology unit, then is also a cartilaginous, okay, joint. So the first rib going then, no, that's an amphiarthrotic. Okay, all right, so we've got then cartilaginous joints. Then the third type are the synovial joints. In the synovial joints, where we have then this very complex structure at that intersection of the two bones, is enhanced by fluid within that joint capsule. So that allows for more flexibility. Okay? All of the synovial joints are diarthrotic. Each structural class has subclasses. So, for example, we go to the fibrous joints. Okay? There is no joint cavity. Okay? Instead, we're going to have some kind of a suture or some kind of fibers that hold it together. Typically, they are synarthrotic joints. They're the least movable. I don't like to say immovable because until they ossify, there's still some flexibility. Okay? So sutures are an example of a fibrous joint. Those fibers are then going to hold the bones together. And then when the bones become ossified at that suture line, we call that a synostosis. So when it osteo, referring then to bone, and now we've replaced the fibers with bone. Okay, so the sutures become non-existent. They're replaced with bony tissue. The second example of a fibrous joint are the syndesmoses. And this is where I'm going to have, it acts more like a connection and hold the bones together. There's not that much play associated with it, okay? So that would be then this ligament that holds the tibia and the fibula together. There's really not any kind of free movement there. It's just binding it together, okay, at the distal end. Okay, so we're gonna find it at the tibia to the fibula, and also the radius to the ulna. So when we get up here down to the distal end of the radius and the ulna, I'm gonna have a little bit of fibers in there that are gonna then hold the two bones together. Okay, so that's a syndesmosis. Then the third are the gomphoses. So the gomphosis is where we have the teeth. An example would be then the teeth fitting into the alveolar process and then being connected and held in place by way of this periodontal ligament. So there's a ligament that holds your teeth in position. So your teeth are not fused. There's some flexibility. And as you have gum disease and you have then less connection, you have more range of motion. You have more flexibility with that too. So the alveolar process, you'll notice that on the bones it has that little ridge that kind of sticks out. That actually is a pocket into which the bone or the tooth fits, and then you're gonna hold it in position by way of this ligament. So that's a gomphosis. It is an example of a fibrous joint. It is also known as a synarthrotic joint. So what you want to do is you want to kind of get this back into learning and being able to recognize it. Just put synarthrosis, give the examples, right? So that you can see it, and then that is an easier way, because this can get kind of confusing, especially when we're starting to give some specific examples, okay? So I would write that out. Question?
So like with kids, they have like loose teeth.
Uh-huh.
Is that because like you have fibers or something, or is it like have to do like the growth?
It's a combination of the two, because you know the what is it? You've got adult teeth and you've got child teeth, right? So as you get older, you've got to replace those and give some ability for the adult teeth to come down. So they intentionally are going to start losing their connection. So at 5 years of age, or whatever the age is, somewhere 4, 5, 6 years of age, they start losing teeth. Okay, and that's just kind of the progression of the strength of that ligament, and also the developmental stages that are inside the jaws to begin with. Okay, so these then are my fibrous joints. Okay, cartilaginous joints. Cartilaginous joints, I've got two types. Again, what's holding the bones together would be then my cartilage. So that's why we counted when we did the T5 or T6, and we counted the number of points of attachment. We had to cover the vertebrae body above it and the one below it, because that is actually a joint there. So we're talking about then those two articulations associated with the body of the vertebrae. So in synchondroses, we have a hyaline cartilage here, which then is, at that point, it's called an epiphyseal plate. But when it ossifies, it becomes then the epiphyseal line, right? So whenever I have any hyaline cartilage, okay, I'm going to have that as a synchondroses, where it's instead. So these are all, again, synarthrotic. And a good example would be then the epiphyseal plate, and also that first rib to the sternum. So you can see right here. Okay, so I'm going to ask you, anything that's on a PowerPoint slide, I'm going to put on the test. Which of the following locations would you expect to find a gomphosis? Okay. Which of the following locations in the body would you find a synchondrosis? Okay. And give which of the following are examples of that? I take everything out of these PowerPoint slides. You probably figured that out, right? And that's why they're listed again on your study guide. Just reinforces are you able to describe that? So there's no magic to this. It's just a matter of just kind of sitting down and just processing it out. And if you've got to look at the PowerPoints again, do so. You know, that gives you that visual to reinforce it. We're going to do that. The next example is the symphysis. So we have then hyaline cartilage on the articulating bones. Because we always thought, whenever I have compact bone, don't I have articular cartilage? What kind of cartilage is that? Hyaline cartilage. And then in addition, I'm going to have a fusion of that hyaline cartilage with fibrocartilage. So that little piece of fibrocartilage in between then is going to be part of a joint called a symphysis. And so the vertebral, the intervertebral discs and the pubic symphysis are both examples of that. Okay? So which of the following types of cartilage would you find at a symphysis? Hyaline cartilage on the bone, and then between the bones, fibrocartilage. And remember, fibrocartilage is adapted for compression. So when I'm standing upright, I'm going to have a compression then of my vertebrae, the vertebral bodies on each other. So I'm going to have fibrocartilage. Now, you'll kind of, if you can you picture where those discs are relative to the intervertebral foramen? So we go into the lab and look at that. So if I have a slipped disc, then it can then pinch on a spinal nerve that exits out from the spinal cord through that intervertebral foramen. So you can understand then why you'd have pain, or you have pain sensation, inability to probably have some muscle contraction. You've got a lot of things that can happen as a result of a slipped disc. Okay, so these are cartilaginous joints. The synovial joints are the most complex. They're all freely movable. And so most of my joints, the most abundant, are going to be then my synovial joints. So let's go ahead and look then at the general structure. Okay, so first thing you're going to have in a synovial joint is going to be my articular cartilage. We already learned that, so we're okay with that. On the ends of the bone, we're going to have this articular cartilage. Now, you noticed also on that previous, notice where we had the body of the vertebrae, it has hyaline cartilage as well, doesn't it? And even the bones that are associated with your wrist and your ankle also have my articular cartilage, okay? Because those are also synovial. So the articular cartilage is one component of that joint. In addition, I'm going to have an articular capsule. So if I look at this construction here, the articular cartilage is at the ends. We already learned about endochondral bone formation, so we know that we're going to have some residual hyaline cartilage there. In addition, I'm going to have this membrane, a synovial membrane that's going to be continuous with this articular cartilage and that one. And it's going to be all the way around. So that synovial membrane is epithelial in origin. It produces then a synovial fluid that goes into that cavity. So I'm going to have then this synovial membrane that's going to secrete the fluid, and then around it I'm going to have, continuous with my periosteum, I'm going to have this fibrous capsule. Okay, it's continuous with the periosteum, and that combination of the membrane and the capsule is my articular capsule. Okay, so I have an articular capsule, okay? And that membrane then is going to produce a lot of protein-rich fluid that's going to maintain the synovial, maintain the hyaline cartilage in that joint. Okay. That space in there is called the joint cavity or the synovial cavity. So it's fluid-filled. We learned about air-filled cavities. What do we call those?
Sinuses?
That we found in the skull.
Sinus?
Sinuses, right. So what do those sinuses, they're air-filled typically, but they're, anytime I have an opening, isn't it lined with epithelial tissue? You already know that. So I have this air chamber that resonates to make sound, but when it's irritated, when it's inflamed, it will start secreting fluid and fill that space in with fluid, and then it becomes very nasal, okay? So the sound does not bounce off the walls. It's like hitting water, and so it sounds very like you got a cold, okay? And why is that membrane gonna do that? It's been irritated. So if I have then an inflammatory response, the fluid is gonna try to get rid of the stuff that's causing the problem. If you've got a lot of allergies, okay, when the pollen comes in, you're gonna start secreting more membrane, more fluid, which is then gonna try to remove that allergen from your body. So here we have then a cavity, but it's fluid filled. So my paranasal sinuses are air-filled sacs, or air-filled cavities. That fluid that we find in that cavity is called synovial fluid, and it's rich in phagocytes. These are white blood cells. So what do you think these phagocytes are gonna do? Do what? They're gonna engulf anything, that bacteria that can come in here. So their job is to help protect that location, okay, from whatever invading material there may be. So if you fall and you scrape your knee up, well, you've then maybe breached that capsule. You might then have debris coming in. You want to get rid of anything that's in there. Okay. And then the last part is that with my synovial joint, this by itself, if I just simply have my fibrous capsule and my membrane, that might not be strong enough. So in addition to that, I might have some reinforcing ligaments. The ligaments are, again, continuous with the periosteum. They're stronger than that fibrous capsule. The fibrous capsule just gives some strength to just that space. But if I want to connect the bones, you know, I have to have lots of different ligaments that hold the bones together. Like an anterior cruciate ligament, ACL, or a posterior, any of these ligaments hold the bones together. It reinforces the strength of that cavity or that joint. So these are the components that you're gonna find in a synovial joint. Now these are gonna protect the joint. I'm gonna have one more thing that's gonna come in, muscles. So when I have a muscle crossing the joint and attaching onto the bone below it, then that helps to reinforce and stabilize that joint. So my quads, they're in my anterior thigh, but they come down and they're going to then insert on my tibial tuberosity. So that means they're gonna cross over the joint, okay? And that then strengthens that joint from injury, okay? Now these joints are highly innervated and highly vascularized. Makes sense. If I've got phagocytes in there, then that means I've got to have some blood supply that's able to bring those white blood cells to that location. Now these next two slides, I'm not expecting you to memorize this. The ones that I really want you to know are the ones that are listed in the outline in the PowerPoint. Those I expect you to know for the test. But I think most of you can figure out, oh, these must be, you know, different kinds of joints, and you can just move the bones and you can tell what kind of joint they are. If they're freely movable, then they're synovial joints, right? Diarthrotic joints. Okay, so each one of these kind of goes over that. I'm not gonna, if you are PT kinesiology, this is what you might want to spend some extra time on. But those who are going in the other fields in allied health, nursing, you're not gonna, this is not what you need to know. So if you're going into the other, you might want to take a little bit of extra time and at least look at those. There are some things that I'm going to be pointing out. Okay, so we have in my synovial joint some additional features that are going to reduce the friction. So let's kind of first split this up. Synovial joint components, that's what I just covered. The articular cartilage, the articular capsule. Those are the components. Those are what we're going to find in the joint. Now, I'm going to part 2. Synovial joints. What types of features do I have to help reduce the friction? And they include then the structures that we talked about and some additional. Okay. So I just wanted to make certain that you're clear of what we've been, you know, the previous slide to what we're doing here so you don't get confused. One is, hey, this is what you find in there. So the question on the test will be, hey, which of the following does not appear as part of the structure of a synovial joint? That would be, then you go through and you figure out which one doesn't belong there. And then which of the following help to reduce the friction at a synovial joint? See the different kinds of questions that you can get from that? So I just want to make certain that you're able to then see the difference. So one structure that you may find at a synovial joint are bursa. So bursa, here's an example of a bursa. They are fluid-filled sacs. They're fibrous sacs, and they have the same fluid component as what you would find in the joint. So they've got synovial membranes with synovial fluid. Now, if you look at this, here is a ligament that is going to cross over this portion of my humerus, but I don't want it to rub on it and cause damage and pain. So I might see in here a bursa. It's got the little extra padding to help protect it. That's all it is. So that's what a bursa does. Now, we're all born with a certain number of bursa and certain locations of bursa, but depending upon your occupation, you might have additional. Let's say that you're a farmer working in the farm, and you've got a lot more manual labor that you're doing, and a lot more potential damage to the bones. You might develop a bursa that not everybody has. It could be an addition due to then your occupational work, okay? So you can have that. So again, wherever you have tendons, ligaments, anything that's going to then appear where the bones come together, you could potentially have a bursa associated with it. Okay. Another one is a tendon sheath. Now take that sac, which is like rounded, flattened, and now stretch it out and then have the same structure but elongate it and wrap it around the ligaments. So that is what we call a tendon sheath. So for example, those of you who know somebody who has carpal tunnel syndrome, all of the muscles that are in your forearm are going to pass down over the bones on your carpals, and then they have to then go to the digits to do all the work, to do all this, okay? When you do repetitive motion, you're typing 40 years, okay? You're an assistant. You are typing. Or if you're working as a grocery clerk and you're doing the same repetitive action, then you're going to get some inflammation. And you then have carpal tunnel syndrome, which is tendinitis. So in the tendon sheath, because these ligaments are going to pass through a tendon sheath to get to their destination, to help reduce then the friction. But as you get older and as you have more of the same kind of action at that joint, you're going to start causing inflammation. And so sometimes it might require then surgery in order to get those tendon sheaths and the scar tissue that's been building up in there so that you have more range of motion, okay? So the tendon sheath is an elongated bursa. Wraps around a tendon. Tendon connects muscle to bone. So what it's doing then, it's trying to then protect the bones from any further friction damage, okay? So now we looked at structure. And now this slide, the one we just looked at, described some of the friction reducing components, bursa, tendon sheaths. Now looking at the synovial joints, what can we do in addition that's going to enhance the stability at that joint? Okay, what other features are going to strengthen then that articulation? Okay, so the first one would be articular surfaces. Some bones literally fit into a socket, and the portion of the bone that fits into that little socket is going to be similar, it's complementary, and when it fits in there, it reduces, or actually, it enhances the stability at that joint. So if I'm looking down at the head of the femur, and it's fitting into the acetabulum in the os coxa, there's a nice snug fit. So that keeps that joint more stable. In addition then, if I take and add an additional ligament right here, okay, and attach it into the wall of that acetabulum, then it even strengthens it even more. So the stability is enhanced by the fit, okay, complementary fitting like that, and then a ligament that's going to attach it onto that. So on the head of the femur, you'll find a little depression where the ligament is going to connect the head of the femur into the acetabulum when we get to the lower appendicular skeleton. So you get a snug, stable fit. So that's going to be one way that I can enhance the stability. Okay, make it fit really nicely. Have a ligament that kind of connects it all together. That's going to enhance it. So that ligament in that location is going to help. So for example, when I looked at my knee and I have my anterior, posterior, medial, anterior cruciate ligaments, then that means I've got ligaments that are holding the two bones together. Okay, that's going to add stability, prevents excessive motion. Now, because the knee, all that's protecting the front of the knee is your little kneecap. You know, there's not much, but you have muscles that you can strengthen that joint either on the anterior side or the posterior side, whether through your quads or through your hamstrings. So the attachment then is going to enhance the stability of that joint. So what we do then is at that joint down in my knee, if I were to, and those of you who might be into sports know that when you have an injury, like if somebody hits the side of your knee, like in football, and you get a torn ACL, hey man, you're out for about a year. Because that ligament is made up of what? Histologically, what kind of tissue is it?
Connective tissue.
It's connective tissue, but it's a ligament. So what's ligaments? It's going to be dense, regular connective tissue. And if you've got that, is it vascularized? No. So it takes forever to heal something like that because there's no blood vessel or there's not a good blood supply going in there. So it takes a long time. So when you know that somebody got, so when they say, oh, they'll be out, I play fantasy football because my husband does that kind of stuff. Don't know anything about it, but I just join them. And so what happens is that when they say, oh, they got a torn ACL, I'm going, oh, well, that's, my guy's out. He's out. He's not going to play anymore this season. Oh, they'll be back in 6 weeks. Oh, yeah, right. Yeah. You put them back in the field, and then you're going to have damage again to that same thing, that same joint, and they'll be out then even longer. So I just kind of have to say, well, I lost that player on my team. Okay, so we've got then ligaments that are going to enhance the stability of the joint. Another one is muscle tone. So again, I've talked about this a little bit already. When I have a muscle like these quads that are going to have a tendinous connection to the tibia below, the more I strengthen the muscles, the greater the stability of the joint. So most athletes are going to work to improve muscle mass to protect the joints. Okay? You don't want weak joints. You want to maximize the ability of maintaining their stability. Okay, so these then are different conditions that enhance the stability. So which of the following are going to serve to enhance the stability of a joint? Okay, and that would then be the ligaments, muscle tone, articular surfaces, complementary pairing. Which of the following are components of a synovial membrane? That was that first line. The next one was, which of the following are going to reduce the friction at a synovial joint? Which of the following are going to enhance the stability? So you can see what kind of questions. All I do is I just take these PowerPoints, convert them into questions. That's what it is, really. And there's a lot of material, granted, I understand that, okay? But there's no mystery as to where these questions come from. They're right there. Just have to kind of compartmentalize information and then pull it out of the file when needed. Okay, so now, okay, so we'll go ahead and stop here. So I'll begin here on Thursday. Finish that out. Okay, so let's